Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. All right, thanks for tuning in to episode 12 of the Super High Yield Anesthesia Podcast. This is part 4 of the Intro to Trauma Anesthesia series, and today's episode is going to be about common intraoperative complications in trauma. And specifically, the ones that we're going to talk about is persistent hypotension, hypothermia, slightly talk about coagulation abnormalities, and lastly, we're going to talk about most common electrolyte and acid-base disturbances. And like with the previous episodes and the future episodes, their primary source for this content is 3 textbooks, so Miller, Barash, as well as Morgan Mikhail. All right, and if you have some time, I really appreciate it if you do the pre-survey. That's a link in the description. And if not, that's okay. And hopefully you learned something today. And with all of that said, let's go ahead and get started. So probably one of the most common complications you'll see during a trauma is persistent hypotension. And there's many causes to it, but the most obvious one is going to be bleeding, especially, if a patient comes in with a gunshot wound. Most likely the cause of the hypotension is you're just losing blood. So there's a hemorrhagic shock picture developing. So the primary treatment for bleeding is obviously controlling that bleeding. So this is going to be the job of the surgeons, kind of go in, find out where the bleed is, and just stop it. In the meantime, our job as part of the anesthesia team is going to be resuscitating this patient. And in this case, most likely you're going to be using an MTP, so like massive transfusion protocol with like a rapid infuser. So things like using like a Belmont through a large bore IV. So for example, like a 16 or 14 gauge IV, and just pumping the patient full of blood. And if you want an episode on kind of discussing the strategy for resuscitating trauma patients, I would direct you to the previous episode of part 3 of this Intro to Trauma Anesthesia series. Okay, so assuming you properly resuscitated the patient with the blood, you can also use crystalloids, right? And the choice of crystalloids tends to matter as well. And for traumas, and for me personally, I like to use lactated ringer over normal saline, because there's a lot of different problems of normal saline, right? So because NS, it causes more urine output as opposed to LR. Thus, you have to replace that urine output more. It can cause hyperchloremic acidosis as well as dilutional coagulopathy. Yeah, and it's kind of interesting because like LR, yeah, it does have lactate in it. But doesn't actually cause acidosis, but in large volumes, you could run into issues with edema. Okay, so that's the most common cause of persistent hypotension in trauma, like bleeding. Other causes are things like tension pneumothorax, so paying attention to the mechanism of injury. Say, for example, a patient got T-boned in an MVA, then you have some bruising on the left side, distant breath sounds, or lack of breath sounds in general, one side, then you're concerned for tension pneumo. And as we previously discussed in the previous episode, the general treatment for this, the initial treatment is going to be needle decompression, as well as a chest tube afterwards. And we talked about the signs and symptoms in the previous episode, so if you want to review that, I would encourage you to take a listen to that one. Okay, now next potential cause of persistent hypotension is neurogenic shock. And this is generally due to spinal cord injury. And the way spinal cord injuries and neurogenic shock, it kind of presents is hypotension, bradycardia, and warm skin due to the decrease in SVR. And again, it's hypotension, decreased blood pressure. Okay, and the thing about neurogenic shock, like it does respond well to catecholamines, so that's a handy tool to keep in your arsenal when you're trying to deal with these patients. And an important thing to do is try to distinguish neurogenic shock from hemorrhagic shock, because if you misdiagnose neurogenic shock for hemorrhagic, it could lead to excessive fluid administration and all the bad stuff that comes with that. And vice versa, if you diagnose hemorrhagic shock as neurogenic, you can actually be depriving the patient of the fluid that they need. So one of the ways you can try to differentiate this if the source is not immediately obvious is using a TTE or a TEE. So for example, if a patient is having hemorrhagic or hypovolemic shock, you will see the collapse of the left ventricle, and that is like super hyperdynamic. And you'll see what they call it as kissing walls. So basically, the ejection fraction is super high, which means that the heart is trying to compensate by pushing more stroke volume. And that's pretty common in like hypovolemic and hemorrhagic shock. Versus when you have a neurogenic picture, you would have like a preserved heart function, like no big changes. Okay, so that's neurogenic shock. All right, and the last common cause of persistent hypotension and trauma that we'll kind of discuss is cardiac injury. So the most common causes of cardiac injury are things like blunt cardiac injury, so BCI, and pericardial tamponade. So firstly, regarding blunt cardiac injury, the most commonly damaged structure is the right ventricle, because as you know, the right ventricle is the most superficial structure of the heart. So if, for example, if a patient gets into a car wreck, they're a driver, and their chest goes into the steering wheel, then the right ventricle is going to be one of the most commonly damaged things of the heart. Okay, so during this blunt trauma, you're also going to have possible increase in pulmonary vascular resistance from contusions. And what you'll see when you put on a probe to the patient is increase right ventricular pressure. And you'll see the right ventricle kind of shift the septum from right to left. And what happens with this is it decreases left ventricular compliance, it increases its diastolic pressure, and ultimately it decreases cardiac output. So it's almost like a patient has like a pulmonary embolism, that kind of finding, like for example, the D sign that you'll see in BEs. But this is the cause of, except in this case, the cause is going to be blunt cardiac injury. Okay, and lastly, the pericardial tamponade, as you already know, especially if the patient has like a penetrating injury. Tamponade is basically having blood or some sort of other fluid that's inside a pericardial sac, and it compresses the heart so it doesn't pump as well. You decrease in cardiac output, decreased blood pressure, that kind of stuff. All right, so those are the most common causes of persistent hypotension and trauma, and something you should have in your back of your mind as differentials as you're working on these patients. So again, the most common causes: bleeding, tension pneumothorax, neurogenic shock, and cardiac injury. Less common things, but something to also keep in mind of causes of persistent hypotension, things like citrate intoxication from blood products, hypothermia, coronary artery disease, allergic reactions, and a transfusion reaction. Okay, so the next complications that we're going to talk about is hypothermia. So as we kind of discussed previously in the first part of the Intro to Anesthesia series, hypothermia is one of the 3 points of the triad of death, or the vicious cycle. So it's very important to control and treat hypothermia. And many factors come into play and could cause hypothermia and trauma. For example, 1, shock; 2, alcohol intoxication, and which is sometimes trauma is kind of going hand in hand with alcohol. 3, exposure to cold, so especially during the winter months. 4, fluid resuscitation without a warmer. And 5, abnormal thermoregulatory mechanisms. So for example, a patient with like spinal cord injury or something like that. Okay, patients that are increased risk for hypothermia includes patients that have spinal cord damage, extensive soft tissue damage, burn injuries, alcohol use, and body cavity surgery. Because if you think about it, if you have an open abdomen, you're exposing it to the environment, and you're losing heat that way, in addition to insensible losses due to fluid loss. And to kind of drive in the point that hypothermia is bad for patients, There's like many different adverse effects of hypothermia that I'm just going to list out for you. Okay, so 1, acidosis, hypotension, coagulopathy, cardiac depression, myocardial infarcts, arrhythmias, peripheral vasoconstriction, impaired tissue oxygen delivery, blunted response to catecholamines, increased blood viscosity, reduced drug clearance, infection, and lastly, potassium and calcium abnormalities. So hyperthermia, if you got nothing out of this part, is bad. Okay, so try to treat the hypothermic patient. And speaking of which, the ways you can treat the patient is using convective warming systems. So for example, having bear huggers on both upper and lower bodies. You can have warming blankets as well. Just try to keep the patient as warm as possible. And the last option is you try to turn up the heat in the room. Everyone's going to complain about it, but I mean, if it comes down to saving the patient, then everyone's just going to have to sweat a little bit, okay? The other thing you can use is warm fluids. So like if you have pre-warm fluids, use that. Or if you have a hotline, use that as well to make sure you reduce the amount of cold fluids that is going to the body, which will decrease the core temp. And lastly, this is a kind of cool trick that you can do on an anesthesia machine, actually. Basically, you could decrease your fresh gas flows. Because usually, we run our gases like at 2 liters per minute, or maybe 2.5, 3, whatever. But in cases where you're concerned for hypothermia, you could actually decrease the gas flows to like 1.5 to 1 liters per minute. And by decreasing the fresh gas flow, you're basically not blowing off as much heat as you would with a higher gas flow. So that's one thing you can do. So again, treatments for hypothermia, because hypothermia is bad. Convective warming, so things like bear huggers. 2, warm fluids. And 3, decreasing your fresh gas flows on your machine. Next is coagulation abnormalities. I'm not going to spend too much time on this particular topic, mainly because I discussed it in the previous episode. But essentially, quick recap. In trauma patients, coagulation and coagulopathy is going to be a big issue. So having regular lab samples to get, so for example, tags or ROTAMs, whatever your institution has, is going to be crucial to taking care of these patients because it's going to tell you at what part of the coagulation process is broken, and that guides you on what blood product to give. Okay, so the last thing we're going to talk about today is electrolyte and acid-base disturbances in trauma, specifically hyperkalemia and metabolic acidosis. So for hyperkalemia, the general causes of hyperkalemia and trauma is basically cell membrane permeability and shock. So as the cells kind of basically die off because you're not getting the oxygen it needs, you're going to have potassium efflux into like the system basically. And this is going to cause the severe hyperkalemia. You also see this in reperfusion injury as well after a repair of a major vessel, because basically before the repair, the tissue is going to be underperfused and it's going to be ischemic. So once you start bringing blood flow back to the ischemic regions, it's going to release all that potassium back into circulation, because again, when cells are ischemic, it's going to increase the membrane permeability and release more potassium, right? So basically you're just picking up all that trash and just circling it everywhere. The last major cause of hyperkalemia in trauma is if you're rapidly transfusing blood products really fast. So basically greater than 1 unit per 4 minutes, it could increase your plasma potassium levels. And generally, the treatment for this, as you already know, there's like 2 different types of treatments for hyperkalemia. There's temporizing factors, and there's ones that actually eliminates potassium from the body. So the thing that actually eliminates things like giving Lasix or K-Exolate or something, those are not really things you can do in a trauma. So for example, if the patient comes in with hemorrhagic shock, they're losing volume, giving Lasix to control hyperkalemia is probably not the best idea because that's going to cause you to lose more fluid. So maybe not that. And obviously K-Exolate, that's going to take time because they have to poop out the potassium. So you're obviously not going to, save or reduce their potassium from them pooping in the OR. So those major things that you usually do on the floor to control hyperkalemia is not going to be as relevant in a trauma case. So we're going to pretty much shift over to the temporizing stuff. So things like insulin, 10 units IV plus 50% dextrose. And you can repeat this 2 to 3 times at 30 to 45 minute intervals. You can give an amp sodium bicarb. So that's 8.4%, about 50 cc's. And if you see like any evidence of dysrhythmia, so for example, you start seeing like peaked T waves or widening QRS intervals, things like that, good idea is to give calcium chloride, about 500 milligrams, and kind of go from there, because giving the calcium stabilizes the cell membranes. Okay, so that's hyperkalemia. And lastly, we're going to talk about, briefly talk about metabolic acidosis. And in trauma, the most common cause of metabolic acidosis is going to be shock. Other causes are going to be things like alcohol lactic acidosis, alcohol ketoacidosis, DKA, and carbon monoxide and cyanide poisoning. In ways you can try to tease out the cause of the metabolic acidosis is a bunch of labs. So things like anion gap, blood lactate, urinary ketone bodies, blood sugar, and volume assessment. Okay, and going over the differentiating the different types of metabolic acidosis is going to be a talk for another time. But, just remember the mnemonic mud piles that we learned and just go from there. And to wrap this up, we're going to talk about treatments for metabolic acidosis, and basically treat the underlying cause as a number one treatment. And in general, if you have a metabolic acidosis going on, try to avoid sodium bicarb unless the patient is super acidotic, pretty much pH less than 7.2, to basically buy you time to figure out what's going on. And the reason why we want to avoid it is it could actually cause a leftward shift in the oxyhemoglobin dissociation curve. So basically, when you shift to the left, you decrease the amount of oxygen unloading to the tissues. And that's obviously what you do not want in case of shock, right? Because shock is global tissue hypoperfusion, lack of oxygen, right? So you want the graft to shift to the right to unload more oxygen to the tissue. So sodium bicarb is not great for this particular instance. You induce like a more hyperosmolar state due to the sodium loading, because sodium bicarb is super, super concentrated, more so than like 3% hypertonic saline. It could cause hypokalemia. You can overshoot and cause alkalosis. And lastly, you can cause intracellular acidosis if you're not adequately able to ventilate the patient. So that's why if you notice, if you ever push bicarb, you'll see like a rapid increase in end-tidal CO2. So that's pretty much what happens. Like I have to take a look at the conversion equation again, but basically through the chemistry formula thingy, so you have, if we have increase in bicarb, it's going to force the equation to the right, and one of those byproducts is going to be CO2. Actually, hold up. Let me take a look here. Le Chatelier principle. There you go. Okay, now, okay, I don't know where I left off of this, but basically, one other reason why you kind of want to avoid sodium bicarb in most cases is because it actually could cause like a paradoxical acidosis from giving the bicarb, right? So you take a look at the formula, like the chemical reactant formula. One side you have the bicarb, and then eventually if you have carbonic anhydrase that's in like the kidneys and whatnot, converts the bicarb to CO2 and water. So you're like basically through Le Chatelier's principle that we learned in general chemistry, basically by increasing the amount of bicarb, you're shifting the equation to the other side, so you can make more water and carbon dioxide. So that's obviously going to make the pH a little bit worse. So that's one of the other reasons why you don't use or try to avoid using sodium bicarb unless you're really trying to buy time to figure out the underlying cause of the acidosis. All right, so that is the end of this episode. Thank you very much for making it to the end. If you have some time, I would really appreciate it if you're able to fill out the post survey. And A fun fact I have for you today is a crocodile cannot stick its tongue out. All right. So if you guys have any feedback at all on this podcast or this episode in particular, you can comment on the website or follow me on social media. So things like Instagram, Facebook, all that kind of stuff. Links in the description. So I would love to hear from you. Always looking for some feedback to kind of improve this podcast. So yes, I'd love to, looking forward to hearing from you guys. All right. With all that said, this is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.